Hello, once again, folks. Abnormal psychology. The subject today is how do you assess a client when they sit in front of you? And the first thing that we'll talk about is what is the goal overall of a clinical assessment? Eh? The overall goal is to find out why a person is behaving abnormally and to spotlight the direction of treatment, not to find or determine individual treatment goals, but in terms of spotlighting the direction of treatment. And the focus is entirely what we call idiographic. Idiographic means to the individual. So we're seeing the person as a unique individual who is separate and distinct from all others, and the focus will be on just that person. Okay? So I have a discussion of a study by David Rosenhan in 1973, who took about a dozen people to 20 different, couple dozen people to 20 different psychiatric hospitals, and each of them, I believe they were mostly graduate students, and he instructed them to tell the intake person at these psychiatric hospitals to complain of one symptom only, that they would hear a dull thudding sound or an empty sound, and otherwise they faked their names and occupations but were honest about their personal histories in spite of that. So they were all admitted, okay? and upon admission they all behaved normally. Now the question is, if you were in those shoes of the people who were Confederates, they are people who were in on it and trying to see what would happen under those circumstances, what do you think would happen? Do you think that any of them would be immediately released, or do you think some of them would, or do you think all? What do you think the outcome would be? One of them was diagnosed with what was then called manic depression. Now we call it, of course, bipolar disorder. Every single one of the rest of them were labeled as having paranoid schizophrenia. We don't use that terminology anymore. Schizophrenia is no longer broken up into those names, those subcategories, but they were all diagnosed initially as schizophrenic. Interesting, yes? So the question that Rosenhan wanted to have answered more than any other is, at what point would anyone detect that they were not schizophrenic? And it never happened. Even after the study, when they were informed of the individuals who were in on it and Confederates to the study, they called some of them schizophrenia in remission as a diagnosis. Perfectly normal behavior was interpreted as being consistent with abnormality, such as when more than one patient would write into their diary or their notes on sheets about what was happening while they were in the hospital. That was labeled as writing behavior. And normal behavior, such as having some disagreements with one's father, was seen as the development of family conflict. Just all sorts of normal behavior was pathologized. Now, this was 1973. This was a turning point year in psychiatry and psychology. You may recall a discussion telling us that in 73, the pathologizing of homosexuality ended. It was taken out as a diagnosis, as a disorder. And a few other things took place in that year, but But I think it's important for you to know that, you know, what do we have here? We have here a tendency to fulfill what we believe our job is, and the job in psychiatric hospitals is to tend to see pathology even when there isn't any, or not to follow closely enough, at least at that time. I think we're doing a much better job now, but one must be reminded to think ideographically and to be very careful to follow up on patients over time and to not pathologize normal behaviors. Do you think that you could fool a psychologist or psychiatrist if you wanted to, and it would nothing substantially awry with you? Do you think you could make them believe that there was something wrong with you? It's an interesting question, isn't it? Well, here are some tidbits. The diagnosis and treatment of psychological/psychiatric disorders exists exactly at the junction between psychology and psychiatry, between psychotherapy and medicine. Now, MDs and DOs diagnose and prescribe medication. Some offer talk therapy. I don't like sending clients to physicians for medication other than to psychiatrists, but you may know that most people prefer to get their medication from their family physician because they have an established relationship with them and because it's more secretive as to why you're there. So if they're concerned about a stigma associated with receiving treatment for psychological problems, that would not be something that could be divulged in that way. So now psychologists and other therapists, in addition to those to a smaller number of psychiatrists relative to the total number of psychiatrists, offer talk therapy. They provide psychotherapy, therapy, counseling, those terms being roughly equal, roughly. Now, what do good clinicians need, in this assessment process? What do they actually benefit from? Well, one is being very calm and steady, not having reactive emotionality, not having so much empathy, I guess I'll say, that you take in the emotions of your clients left and right. That would be something, if you do that you must work on, yes? Control, self-composure, clear judgment, being able to be frustrated without any resolution to that. That's part of the game. So, some clients disappear, so without any explanation, they see you for a while and they're gone, or they don't come back after the first session, and you may not know why. Often you don't. Lots of patience, so you must have that. Clear communications, very clear. You don't use muddled vocabulary, that you speak in words that the client can understand. You don't use psychological terminology. You just make things as simple as possible to everyone if they want to know details, And so critical thinking skills, so you're able to think as objectively as possible about what you believe you're seeing and hearing and so on, So that's a partial list of some of the important qualities. Now, is everybody always possessive of these qualities? No, that ebbs and flows, but it's important that you acknowledge what you do well and what you don't do well as to those qualities and work towards improving the ones that need improvement. So if you have a lot of anxiety, a baseline trait anxiety that's high, you need to work on that so that you can become, in the presence of others, particularly clients, more calm and steady. If you tend to over-explain things and you like to use jargon, then you need to work on how to explain things to people that is in a language they can understand more easily. The average person does not understand any kind of dense jargon, and we shouldn't expect them to. Especially if you're using it to show how smart you are. That's not okay, is it? Right. So now let's talk about some of the tools and techniques that we might use in assessment. Okay. The first thing is clinical interviews, observations, objective tests, checklists, questionnaires, those kinds of things. We might use those. I like to use a couple of different ones. Projective and subjective assessments. We'll get a medical history, we'll get a school and work history, we'll get a family history, yep. And what you do will always include a clinical interview, always, which is an art form that is not frequently taught to a significant degree. I'm here to tell you. It's something you can teach, and of course there's on-the-job training associated with that in all of these, but it's much easier to start with good training. Behavioral observation. It's amazing what you can tell. Excuse me, my nose itches. It's amazing what you can tell just by watching what people do and what they say and how they say what they say and so on. This assessment might involve psychological testing, maybe, often, if what you're talking about are simple survey assessments or behavioral assessments, just brief things, yeah. Might involve a referral for a physical exam, to rule out some things that you think might be going on, or to just make sure that you're checking it out. So, for example, in the case of sex therapy with couples, you have a report of a husband who is talking about his difficulty in attaining and maintaining erections, and he's 50 to 60. Well, you would want to get at least his family physician to measure testosterone levels. That would be a minimum thing you would do. But that would be prudent. So it might involve a referral to a physical exam. It would rarely, if ever, as a master's or even PhD level clinician, involve neuroimaging referral, rarely neuropsychological testing. The one example of neurological testing you might recommend more than for other reasons would be thinking or hearing or getting a report from family or individuals, often family, that a person's is having greater and greater trouble remembering things and forgetting things. So you think maybe there's a dementia, which is only one possibility that explains such things, but after eliminating some other things, you think maybe, then you might recommend a neuropsychological testing, which is a battery, an all-day kind of thing, a battery of tests, subtests, and a big report. It's expensive, and so for people who don't have insurance, it's very prohibitive in terms of cost, but it's extraordinarily useful. All right, so let's go to the next video so that I can get into great detail about what we call the mental status exam. All right.